Good morning. Okay, I love that because I only had to say that one time. Thank you all for coming, and I'm going to ask my doctors to join on the panel. We have Dr. Clark, who is a professor and chief of gastroenterology and hepatology at Penn State Health. We have Dr. Stacy Pearson-Wharton, who is a psychologist and the dean of health and wellness at Susquehanna University. We have Dr. Robin Screen, who is a breast surgeon at Geisinger Health System, and Dr.
I'm also the director for breast surgery.
And she is also the director of breast surgery where? At Geisinger. Okay, so let's, very big deal. I told her when I came back in my second life as a physician, I was going to be a breast surgeon. So... And we also have Dr. Arthur Williams, who is at Hamilton Health Internal Medicine and specializing in HIV and drug and rehab. I'm Dr. Siobhan Momon-Nelson. I'm an OBGYN at UPMC Carlisle. I see many familiar faces here. Again, thank you all for coming. This is, when we said it was the Ask the Doctor panel, this is very interactive. We are not going to sit up here and talk. We want you all to ask questions. We're going to go back and forth and so forth. If you saw me earlier, you probably got one of these index cards, and you can either ask your question, but if you have your index card, if you stick your hand up, I'll grab your index card and I will ask the question too, because I don't want to put everybody on the spot and make them feel like you have to use the microphone to ask questions. So that's why I got the little index cards for anybody who wants one. If you want an index card and you didn't get an index card, please just signal me and so forth, and then we'll go from there. I typically like to do an introduction. However, I think it's also nice for my colleagues to kind of say something about themselves. So I'm going to pass the microphones around because I'm going to ask them to tell us one thing that's very important about what you do that you want everybody to know today.
Introducing ourselves as well.
Yes.
Good morning, everybody. I'm Dr. Stacy Pearson-Wharton. I'm a psychologist, and I have been doing this work for about 30 years. My specialty specifically is working with Black women around their trauma, their stress, their race-based stress, as well as just to live a good life. What happens for us lots of times is that we are dealing with something and we're dealing with something on our own, or that we don't want to seek out help, that we are operating within the Strong Black Woman framework. But I'm here to tell you today that asking for help and getting help is not a sign of weakness, and in fact is a sign of strength. It is not just something that only white people or white women do, because that myth is out there as well. But in fact, we do seek therapy. I oftentimes tell people you don't have to feel that way, that you can get some help. And so if you're struggling, you know somebody who's struggling with mental health, with depression, anxiety, they can get help.
So I'm Dr. Arthur Williams. I'm at Hamilton Health Center. I've been there now for 20 years, and I specialize with the HIV program. That's how I first came. Ms. Peterson asked me to come up. Your sister and my sister, because I'm also an alpha, asked me to come up and start the clinic here. And my first thing is that HIV is still running rampant through our people, especially Black women of all ages, especially Black men. So in the back, you'll see there's a black tent back there, and you'll see that we're doing HIV testing, so I recommend everyone go back there and get tested. If you know anybody that needs any help with HIV, unlike the other facilities that treat HIV, I will see a person within 24 hours to get them treated. The other thing that I'm doing now, I was blessed to actually, again, at the behest of Ms. Peterson, became an MAT specialist, medical assisted therapy, to do drug and alcohol. And I do more than just opiates or heroin the big issue now that I'm trying to get out is that we now have a treatment for alcoholism, and a lot of our people, our black people, are having issues with alcohol, especially in Harrisburg. Our older black male population too. We now have a medication for them. We also treat people that are on crystal meth, cocaine, as well as heroin. So I tell everybody, if you know anybody has a problem, get in touch with us, and we'll get them the help they need.
Hello, I'm Dr. Robin Screen. I currently reside in Danville, Pennsylvania. I'm the Director of Breast Surgery for Geisinger Health Systems. I am very glad to be here and share my knowledge. There's a lot of confusing information about breast health and breast screening. I think it begins with taking care of yourself because you can't be healthy until you put yourself first. I chose breast surgery because I love surgery, but also treatment of breast cancer. My mom, 2 of her 3 sisters, my cousin and grandmother all had breast cancer. So it's very much a part of my life, and I wanted to be there to make a difference. It allows me to be compassionate and understanding for those who are going through that diagnosis or have that worry or fear.
Thank you, all of you, for having me here again. I'm from Penn State, Hershey. I think I've been here for the past 3 or 4 years. Thank you for asking me back. I'm a GI physician. Most people don't like to speak to me when I tell them they need a colonoscopy. Our job is not just to do colonoscopies, but to talk to you about different ways of screening. And so this morning, I hope we can share our thoughts and knowledge and some of the things we're doing locally to help you adopt the screening. Let's not for once think that colon cancer screening is not something we see in our community. Let's not also think that the management is any different, our disease is different. The big difference is that we don't pick these things up early because we don't ask for screening early enough. So I'm glad to stay as long as you need to share my thoughts on that. Thanks for having me.
And again, I'm just going to say that I'm an obstetrician gynecologist. Like Dr. Screen, I actually chose OBGYN as a specialty because I like surgery. A lot of times people think, oh, you wanted to deliver babies. I'm like, no. You know, that became part of what I had to do to be an OBGYN. However, I really into more the GYN than the obstetrics. And one thing that I want to share with everyone that is here, because everyone that just a quick look, there looks like there's only a couple people that might still be of reproductive age, but there look like there's a bunch of mature women that are here in the crowd. And I want to focus on the importance of prevention, because a lot of times people will say things like, oh, I don't need to see you, I'm not having any babies. I don't need to see you because I don't have any problems. I don't need to see you because, I'm not sexually active. I don't need to see you because I had a hysterectomy. That is not true. You still need to see a gynecologist. So I encourage you to make sure that you are doing your preventative womanly care, just like you are doing your heart and your lungs and all your other care, so forth. So I did get a question, and we all know that October is Breast Cancer Awareness Month, and so this was probably the best question to kind of start off with. The question says, this person is a 10-year breast cancer survivor. How important is it to continue biannual or bilateral ultrasound and mammogram? And I will even add any additional imaging that is recommended.
It shouldn't be biannual, it should be annual. If you look at the recommendations of the American College of Obstetrics and Gynecology, the American Society of Breast Surgeons, American College of Radiology, their recommendation is annual screening mammograms beginning at age 40. If you have a diagnosis of breast cancer, then we in my clinic consider you at high risk for life, and we follow you in our high-risk breast clinic annually. The way that we do it is you get your mammogram that same day, that same visit. You're also seen by one of the providers in our high-risk breast clinic. In addition to mammograms, if you have dense breast, or if your cancer was discovered only on MRI, we also add supplemental screening in the form of breast MRI. But we really recommend that even if you're 10 years out, you continue to be followed.
Okay, I told you we were interactive. So, show of hands. Who's all had a mammogram? All right. Okay, this is wonderful. Show of hands. Whoever was called back to do additional testing for the mammogram? All right. that caused a lot of stress, right? So, but I applaud you and cheer you on for actually going ahead and doing that follow-up and doing the recommendations. I do believe that we have some support here today, that if you are not able to get your mammogram or have a hard time trying to schedule and whatever, I do believe that there are some exhibits here that are here. I know UPMC Women's Health Division is actually here today. So before I move on,
Dr. Lynch, can I just add to that?
Yeah.
You probably are seeing this too. A number of women who haven't gotten a mammogram because they can't afford it, they don't have insurance. There are organizations in this state that will help get your mammogram covered. So you need to talk to your doctor. It's different agencies in different places, but you can get a mammogram at no charge, and not having insurance or not being able to afford it is not a reason not to go. So we have a group here that, you know, seems to be on the right track, but share that information with your friends and family.
We have a question over here.
Thank you. It would be for the young lady in the pink. I'm sorry I missed all the names. I have been amiss since I was a young child. My mother suffered from some trauma, her and my grandmother, and my mother never went and got help. So I was more or less the breaker, because I had some things that happened to me that were extremely traumatizing. So until my job noticed that I was being strong and coming to work with tears running down my face is when I went and got help for some of the things that I've dealt with in my life that helped my children, and still I tag team for my youngest son. So I said all that to say I've been paying attention. Is that me? I've been paying attention to a plethora of things in the community, and within the community, I noticed that there's a lot of hurt people that don't want to be healed, but desire to stay within a realm of staying in the hurt. So I am doing some behind-the-scenes things because mental health, amongst some other things, will always be close to me. So I would like to reach out to you personally, and all of you collectively, but I would like to reach out to you because there are some things that I would like to see what we can do to do baby steps or whatever to make sure that the community is aware that there is help. You do not have to worry about a stigma, and that you are the first defense of doing anything. You have to do it for yourself, and then that way, as an example, we can share with others. So if I could, get your information, I would greatly appreciate that.
So, and I think what you talked about is really common among us, if you will, that we often have a hurt, and that hurt is generational, and that it gets passed down from generation to generation. But what I hear you saying is that the buck stops with me, and that we can be better and do better, especially once we know better. And so I have a table here, and so I'm happy to connect with you there. Just to talk a little bit about trauma reactions. And trauma can be everything from a fire to a parent with mental illness, all the way up to sexual molestation. And we're actually currently conceptualizing the repetitive experiences of racism as a trauma as well. And it can play out in a number of ways, including how you manage your relationships, your ability to withstand difficult emotions, along with flashbacks and dreams and all kinds of disruption. And so when those things happen to you, yes, it is really important to seek out help. You would do that if your arm was broken or your leg was not working properly. And so it's really important to do that. And there's lots of African-American therapists out there, and particularly in our state, that can help you. Great site is Therapy for Black Girls. And so if you're looking for a therapist, but you can also stop at my table.
I just wanted to add on that, and yesterday I meant to send you a text message to say specifically, I believe today is October 11th is Black Women's Mental Health Day or something like that. Is that
rest day or something?
The rest day or something?
We're making up new holidays.
Listen, I'm here for it. If it's a day for me to rest, I'm taking it.
Yes,
okay?
Yes.
But I do have a question, but I wanted to ask you if you were given advice to the audience audience today and a bunch of women of color to say, this is how you rest. Could you give us 2 or 3 ways that we could rest?
So the Sabbath is important, and not just the Sabbath that we know of in a religious or faith spiritual context, but the ability to rest your body. And not scroll your phone necessarily, but actually rest your body and your mind. I recommend sleep, just kind of basic 8 hours. That I personally do that, and it is good. I also take a rest. I meditate as well, and that is a wonderful thing to do to help you. There's a great app called Liberate. That is African American focused meditation, as well as Abide, that's more spiritually and faith-based. I would also recommend just sitting and being. Our parents used to call it piddling. Yeah, and so I think they were on to something to be able to sit around and do that. I mean, and even if you are caretaking children, or your parents, or both, or you have a job and this and that and that even just to take 10 minutes in your day and breathe. There's a great book called Black Women Breathe that can help you with that. And I also rest can mean more high-priced things, a massage, or going to the spa, or those kinds of things. But that's hard on the wallet sometimes, and so I'm aware of that. And so just being able to take a time out for yourself is good. And it will rejuvenate you and help you feel less burnt out.
Next question.
Sure, thank you. So I know I'm being bold in here. We are outnumbered, but on behalf of the guys, I think we're a little hurt. How come there's no rest day for the guys as well?
The question that we had was about if you can give a little bit more detail when you're told about the density of your breast. Like, what does that mean, and so forth like that? Is that something to be concerned about, or is that something very common, or whatever?
So breast density has to do with how your breasts appear on mammogram. When we're looking for a breast cancer, it shows up as white on your mammogram. A completely fatty replaced breast, which is what happens to our breasts as they get older, is gray to kind of, I'd say, a dark gray. And young women have all breast tissue, so their breasts are going to be very dense, so it's going to show up as white. So you can imagine if you're looking for cancer in a dense breast, which is all white, you may miss it. So there are different degrees of breast density. We use a system at our hospital where it's A, B, C, and D. A is totally fatty replaced, so that's not dense at all, and probably don't need any sort of supplemental screening. B is scattered fibroglandular densities, which means there might be a few small areas of density, but really nothing of significance. Again, you don't need additional screening. Then you have category C and D. Category C is heterogeneously dense, which means you have a fair amount of breast tissue, and that is considered dense breast. But then there's also extremely dense, which means the mammogram is almost completely white. And there are some women who, as they get older, still continue to have dense breast. What we do know about breast density is that it's called an independent risk factor for breast cancer. So you have no family history, you have none of the other risks, but you have breast that certainly category density D, extremely dense, and you could include heterogeneously dense C, puts you at an increased risk for developing breast cancer. And so it's got a whole bunch of letters and numbers. There's a House bill in Pennsylvania. I liked it better in Texas because they called it Henda's Law. I can remember that. But same sort of thing. The facility that you go to for your mammogram has to inform you of your breast density, and if you do have dense breast, that you can request from your primary care, from your OBGYN, additional screening in the form of whole breast ultrasound or breast MRI or contrast enhanced mammography.
I was back here fighting with this microphone. I'm sorry, but we had a question about misinformation and regarding mammograms and whether mammograms actually the actually mammogram making the imaging worse to look like it's actually cancer, or if the mammogram is causing cancer. As you all are very aware, misinformation is very vast. I say that we are in the era of misinformation. And so with regards to mammograms causing breast cancer and making breast cancer look worse, I just wanted you to finish on talking about that.
Regarding mammograms, there is a lot of confusing information. Some things I hear in the community are radiation, that you get radiation from a mammogram. And you do, but it's a small amount of radiation. How many of you go through metal detectors? You get more radiation from a metal detector than you do from a mammogram. Some people think by squishing the breast that it causes the cancer to grow or leak out. If that were the case, since we've implemented regular mammogram screening, the death rate and the improved survival would not be better if mammograms made the cancer worse. It's not true. It does not. One of the other common things I hear is, well, they hurt. My argument to that is, who in here has children? Did you take them to get their shots? But they hurt. So that didn't stop you from taking them for their shots. Don't let it stop you from getting what you need. There are a lot of myths. Mammograms are very low dose radiation. They are safe, and they are an effective way to detect breast cancer.
We have another question.
My question is for Dr. Stacy, I believe. I have a friend who is in a situation, it's not a domestic violence situation, but it's a situation where she's in like a cycle, where it's a gentleman that she's interested in, and it's been a relationship for some time now. But for me, not counseling towards her, but for me as a friend, and to witness my friend go through devastation where the gentleman's in, he's out, just seeing the toll that it takes on her life, her health. As a friend, how do I aid her? I mean, I'm giving the sister scripture, getting her involved in the church and just trying to be there, but I'm maxed out. Like, what can I do to aid my friend so that the situation doesn't continue to take a toll on her or me too?
Sure.
You know?
So I think that this is very common in situations where there is interpersonal violence or domestic violence or even dating violence. And violence doesn't always have to be a hit. That domestic violence typically starts with laying the groundwork around mind work and manipulation and those kinds of things, gaslighting, those kinds of things. I would continue to try to be there for her, but it doesn't have to look the same way that it currently looks. And so, and I admonish you to think about how you want to be there for her so that when she's ready to come out of that situation, that in fact she's not finds herself solely isolated, because that also is a tool of abuse, is the isolation. And so I think setting boundaries, I have a friend right now who is caught up in polyamory. And that's spouses having more people in their relationship than one. And I've had to distance myself in a way to say, well, she gets to choose what she wants to do, but that doesn't mean that every time she gets sick of it and she's hysterical about it, that I have to be there for her. And so making that choice that maybe you talk to her every third time that she calls, but setting a boundary around that, even with her, and encouraging her to seek out help, just to deal with the stress of it, not necessarily to get out of the relationship. Because I don't know if you remember, but the more you push, the more she could possibly cling. Because again, that's part of the cycle of domestic violence, and so that's what I would be thinking about. I can't hear her.
She said you specifically said domestic violence is not specifically physical.
No, it's absolutely not always physical. That there's a lot that has to happen in order for to be that first hit, throwing of things, making them question their competency, their opinion, isolation from people who love them. Those are things that happen before the person hits, because it kind of builds the foundation for that.
Okay, another question.
So, Dr. Williams, you indicated you're an internal medicine doctor. You spoke about HIV and MAT, but what are you seeing primarily in your practice, and what is it that you would advise us to do in terms of our health on a regular basis?
I think one of the biggest issues we're seeing right now is obesity, hypertension, and diabetes out of control. And I think it's mainly because of the way we eat. We love to eat. It's been part of us as a people. It brings us all together, but we eat wrong. We're eating too much salt, too much fried foods, too much sugar. And I think that it's just getting worse. I mean, we have people now are running to use different things like Ozempic and stuff to lose weight, but they're not really changing their diet. And I really believe the biggest problem in our people is our diet. I think if we change our diet, stop using so much salt, stop frying everything, stop putting sugar in everything. These are all what's this called. Eating processed foods includes the sugar. These are comfort foods. These things make us feel good. We eat them, we release endorphins. I mean, which person, raise your hand if in fact eating a piece of fried chicken does not make you feel good? So the point is, it makes you feel good. Release endorphins after you eat, especially those things you like, and so we get kind of addicted to it. It winds up being addiction. But I think a lot of us, when we think of addiction, we think about alcohol, we think about drugs, but we don't think about food. And I think as a people, a large number of us have a food addiction that we need to work on. But I think, definitely getting your screenings done for your cholesterol, that goes with the fried foods, having your doctor be sure and do a fasting cholesterol on you, as well as looking at your complete metabolic panel, which looks at your kidneys and things like that for high blood pressure, and definitely taking your medicines. And the sister in the back was saying, what can I do for my friend? If you have a friend who has high blood pressure, if you have a friend that has diabetes, help them, remind them, say, you can't eat that, or did you take your medicine, or have you seen your doctor? And when I tell people, regardless of what disease it is, if you have someone, family member or friend close to you that has an issue, get them to the doctor. It's the best thing you do is to get them in the car and go with them.
Dr. Williams, I have one other follow-up question for you, just because you're talking, you have the mic, so I'm going to ask you a quick question. As an OBGYN and as somebody who still takes care of women of reproductive age, one of the things that we always do when women get pregnant is we do a gambit of labs. Like if you've ever had a baby before, they always take all these labs, and one of the things that we check for is HIV. For us, checking for HIV is kind of standard in pregnancy. We actually check for it twice, early in the pregnancy, then we check again when women are about, we say 28 weeks or like 7-8 months pregnant, because the goal is to identify whether the mom has HIV so we can prevent baby getting HIV. But often what I see is a lot of women who get this testing, that's the first time they were ever screened. Now we have again, mature audience. I'm going to take a quick gauge that everybody over here is over the age of 35. So what would you recommend with regards to preventative screening for, again, like HIV or whatever, for a group of this age?
So the recommendation is everybody gets tested every year. And especially if you're sexually active, with the advent of Viagra and Cialis, people of our age group, and I can say are much more sexually active. And again, we recommend everybody get an HIV test. especially if you're sexually active. But right now it's yearly, and for me, what I've learned is that people don't always tell the truth. I don't know when I just test them anyway, let them know I'm doing it. Because some people say I'm not sexually active, but they are. So rather than based on that, I just go ahead and do the test. And again, it should be repeated. One test is not enough. Once you get your first test, you should come back in 6 months and get another one. That pretty much will clear you for that 6-month period, because remember, testing goes backwards in time, not forwards. So if you get tested today and you have sex tomorrow, you still have to get another test in 6 months. The other issue is to be sure you're getting your partner tested as well, and I tell people go with them to get the results and see the results, because again, people don't tell the truth. Another thing we see here in Harrisburg is also hepatitis C. I'm sure my colleague down here will tell you about that. And you want to be sure and get tested for that as well, again, at your annual visits with your doctor. But gynecologically-wise, I'm seeing a lot of your people come to me anemic, because you're not telling them to keep taking their iron after they have the baby. And what's up with that? Why am I taking care of your problem?
I will tell you, you take iron when you get pregnant. Iron deficiency anemia is very common in pregnancy, but also very common in women of color. So I do encourage you all to do that. And I do co-sign with getting tested, and not only testing yourself, but testing your partner, and also confirming that, because there are many times people are like, oh, he just with me, she just with me, and I'm like, they're with other people, but I'm not here to judge. People do not see me because they want to be judged. People see me because they want to be cared for. So, and my goal is just to care for people. I do have a couple of GYN questions, and says, I was told I don't need a PAP after a certain age, and then other question, which was very similar, after childbearing age, say age 60, how often should I get a pap smear? Well, first I want to tell everybody that the current recommendations are, again, this is a mature crowd, so what was probably told for us is different than what we currently do. So if you have a young child or a cousin or a niece or whatever, the current recommendations are to start screening at age 21. So just because the 19-year-old went to the emergency room or the 19-year-old went to the gynecologist, that does not mean that they actually had a pap smear. Just because they had a pelvic exam, that does not mean that a pap smear was actually collected, because we do not collect pap smears until the age of 21. And if you had a pelvic exam in the emergency or urgent care, the likelihood that a pap smear was also done at that time is very unlikely. They might have screened for an infectious disease, they might have screened for a yeast infection or bacterial infection or something like that, but they probably did not do a pap smear. And the reason why they didn't do a pap smear is because that's something that's typically done in the office, because it allows for appropriate follow-up. The recommendations on how often that pap smear is done, it all kind of depends on if it's normal or if it's abnormal. If it's normal, when you're under the age of 30, it's every 3 years. If you're over the age of 30, technically it's every 5. I hold loosely to those guidelines, because sometimes when people hear, oh, you're not doing a pap smear, that means I don't need to come back every year. So let's stop that. Pap smear and an annual gynecological exam are not the same thing. You should see your gynecologist, your PCP, whoever is doing your gynecological care, once a year and have a pelvic exam. How often you do the pap smear, it all kind of depends on what it is. Now, the American College of Obstetrics and Gynecology, that is my governing body that tells me how I practice. They make a recommendation that if you are over the age of 65, or if you've had a hysterectomy for non-cancerous reasons, technically you can stop screening and doing a pap smear. Again, that pap smear is not the same as the pelvic exam, because you should see the gynecologist or have a gynecological exam every year, right? Okay, perfect. Good. Okay. But I will also say that is a shared decision between you and your physician. And the reason why I say that is a shared decision is because if I have a woman who is 66 years old who has a new partner, because it is what it is. We're a bunch of mature people in here. We're grown. We can say the word sex and not turn different colors or whatever. But if you have a new partner or a different partner or whatever like that, that does not mean that you don't have increased risk of getting, essentially we're doing pap smears to prevent cervical cancer. If you have a new partner or multiple partners and you're 66, I'm not going to stop screening you, because your risk factors for getting HPV, subsequently potentially getting cervical cancer, is very likely. We had a patient in my office in the last 6 months who was 70 years old, had a new husband about 3 years ago. She had HPV. At 70 years old, we found out she had cervical cancer. And the only reason why she was screened was because it wasn't me as my partner, but it was a shared decision making about whether we did it or whether we didn't do it or whatever. So those are the recommendations, but at the end of the day, it is a shared decision between you and your physician. If you go and you see your physician and your physician says, "Oh, I don't have to do a pap smear. You don't need one. You don't need one. You don't need one." But together you all don't decide whether you want to get that done. You can come down to Carlisle and see me. We can have a talk about it. I have no problem seeing everybody. I think I see a couple people faces that are very familiar who've come and found me in Carlisle. So that is very important. I have another question about what causes polyps in the colon, and can these be preventable?
No, thank you. So there are several factors that give a risk of developing those. But let's step back a second. Not all polyps lead to cancers, okay? Some of them are benign. We call them hyperplastic or benign. The ones that grow and become cancer as you leave them alone also have different risk, and I'm not going to bore you in all of that. So coming back to what we're talking about, what leads to that? There are a plethora of reasons why that happens. First one is genetics. So if you have a family member who's less than the age of 60, who's developed cancer, then you belong to the higher risk individual. If you have multiple second-degree family members who have polyps, cancer, you also belong to the higher risk of individuals. The second thing is our environment. So how do we learn about our environment? If you look at those studies that have looked at people living in different parts of the world that have moved into the US, even though they belong to the same families, those that remain in their original countries don't have the same risk. So it's something to do with the environment that you've moved into, and we are not sure, but we have some ideas. The ideas hover around things like what we eat. And it's not what you ate yesterday, what you ate 5 years ago, but what you eat over a lifetime, okay? So you hear about people talking about red meat, fish, vegetables, and things of that nature. Where does that information come from? If you look at different population groups who don't eat as much meat as others eat over a long period of time, then their risks are slightly higher, okay? So those are the risks that lead to all of this. And then the final thing that we have to acknowledge, as we all grow older, our risk of forming them also goes higher. So that's why we start screening at certain ages, because the risk is lower when we are younger, unless we have a genetic risk factor that leads to doing that. I also would say that that's not what I was asked, but I'm going to segue briefly into that. If you have a high-risk family history, or you know other members of your family who are less than 60, so I'm not talking about your grandmother, second removed, who's 80. No, sister, brother, cousins, and multiple of them, then you shouldn't be doing the stool examination because you belong to a higher risk individual. Speak to your doctors about that. Last thing is screening should not always be colonoscopy. It sounds very strange as a GI doctor when I say this to individuals. The guidelines never said we should all have colonoscopies. What the guidelines said is that all of us should be screened, and there are several ways of screening, and I'm happy to share that later on.
I do want to say one thing also as I'm talking, looking out here, and the assumptions being made, I think, by some people based on the age. Again, a lot of us are sexually active, and I encourage everyone to get the HIV as well as STD testing done. My oldest HIV patient is a woman that's 86 years old. So she got it about when she was 70. But the good thing about that, though, is she's now 86. We now have medications. People don't die from HIV anymore. People live a normal life. Once you get tested, we put you on the medication, and they live a normal life like everyone else does. Once people are actually on the medication for up to 6 months, they actually can't spread it. So that's another amazing thing. And now we have medications now, an injection that people can get twice a year to keep them from getting HIV. There's a pill that we can tell people that they can take once a day, like a vitamin, to prevent HIV. So I recommend everyone who's HIV, that's called PrEP. And we have a PrEP program at Hamlin Health Center. Again, so if someone's sexually active at this age period, you might want to consider getting on PrEP at this time, which is either a pill or an injection. The injection is once every 6 months for the rest of your life, or the pill once a day.
When we started this health expo several years ago, we focused mainly on women, and then we extended it to men and children and so forth like that. And I am very proud to see a lot of gentlemen in the audience today. And I have 2 questions that really are about the same thing. And the one was, I wanted to ask about, can men get breast cancer? And it says women can check for lumps in their breast to see if there's cancer, but can men do that? And can breast cancer in men be found with blood tests? Like, how do we do that for breast cancer with men?
Let me start with, there is no reliable test to detect breast cancer as far as blood work goes. That's why we get back to mammogram. The 3 key components to monitoring yourself for breast cancer are breast self-exam, and this is typically, we talk about women, once a month, clinical breast exam, which is once a year beginning at age 20, and then your annual mammogram. Men do get breast cancer. For every 100 women who get breast cancer, 1 man will develop breast cancer. It's usually detected later only because they're not looking for it. There is no harm as a man in checking your breast for a lump. Not likely that you'll find anything, but you never know, and sooner rather than later. You could do it monthly, you could do it every few months, you could do it once a year. There's no set standard. But if you have other men in your family who've had breast cancer, that would be a really good reason to do regular exams. And this goes for men and women. Oftentimes, the person who finds the mass in the breast is the significant other. So it's being aware, knowing that men can get breast cancer, taking initiative for your own health, and there certainly isn't a problem with doing a breast exam as a man.
The other thing men can get is something called testicular cancer, and actually men, and again, it's a self-testicle exam, and we recommend men start doing it at age 20, and what you're going to feel is it won't hurt, it's just a hard lump that doesn't hurt. And so again, that's part of your annual exam when you see your doctor, but also men doing self-testicular exams.
I have a couple of GI questions. And the first one, it says, why do you have to see GI when your labs are high? And I would assume that labs maybe like liver enzyme functioning tests or so forth like that are high. And the other one says, could you please offer and educate people regarding home kit for colonoscopy due to the time of schedule and out of patient overload?
Thank you. So let's start with the lab test first. So we presume that the lab test this individual is asking about is your liver exam. And if that's not what it is, please raise your hand. I'm happy to elaborate on that. So just like you heard Dr. Williams say, the liver exam blood work is part of your comprehensive metabolic panel. There are many reasons why that could be abnormal. So if I step out last night, I have some alcohol, and I drink a little more than I'm supposed to, there's a risk that some aspect of my liver test will get abnormal. There are also risks that your liver test will be abnormal from infection, like hepatitis B, hepatitis C, hepatitis A. There's a whole slew of them. So it could be infection, it could be alcohol. The biggest thing that that we are seeing, and have been seeing that for the past 25 years, is something we call fatty liver disease. It has more fancy names, but I'm going to be very real. The whole idea is having excessive amounts of fat depositing in your liver based on what we just heard this morning. Diabetes, being overweight, watching what we're doing. And then certain supplements that we buy from the vitamin shop or anything that we take can also affect our liver. So with all of these things, think about it and say, when you notice it being abnormal, you need to share as much information as you can with your doctor. So if you drink 3 beers a night and you think that's no big deal because your friend drinks 5, everybody is different. You need to share that information so when they start the workup, they need to know what they're doing. The next thing you think about is if you're buying certain herbs or vitamins that somebody said was very good, you need to share that information so we can look at that. Now, fatty liver disease, and please don't leave here thinking that it's a term that's meant to insult anyone. There are more elegant ways of describing it, but if you think about it as excessive fat in your liver, used to be thought of as something that's benign, meaning that it doesn't matter anymore. What we know now is that fat deposited in your liver is not benign. We've actually known that for over 15 years. The biggest reason in the next 5 years why people will need a liver transplant is because of fatty liver disease. Because it leads to inflammation, scarring, and then eventually the liver begins to fail. Now, not everybody will develop that, and the beauty is that we have different ways in which we can manage that. There are medicines you can use, there are certain lifestyle changes you can make that manages that as well. So as I've just summarized, and there are some other conditions that are inherited, which I don't want to bore you about, because obviously as we all get to this age, if these are inherited, we would have found them several years earlier, hopefully. The key message about this is if your liver tests are abnormal, don't ignore it. Have somebody follow up, have them do an ultrasound or additional things that we do. All of us here as healthcare providers are only able to order additional tests based on what you tell us. So if you come to my office and say, oh, I'm not worried about that, and I'm not going to tell him or her about what's going on, you may be shortchanging yourself. Last thing on that before we move to the screening. Dr. Williams mentioned hepatitis C. There are other forms of hepatitis. In today's world, and it's been that way for a very long time, 3 months of pills cures most people from hepatitis C. So again, it's not something to be ashamed of or hiding or thinking about spreading it. So I think switching over to the other side, colonoscopy is when people like me ask you to drink that lovely stuff we send you, clean you out, come in, have somebody drive you, and we pass a scope to screen for cancer. There are other ways of screening for cancer, which is not colonoscopy. So I'm going to spend a few minutes to make it brief. What the guidelines now recommend is at the age of 45, everyone should get screening. There are screening tests that can be done with blood tests. I'm starting with that. We don't advise that yet, even though the FDA has signed off on that. Why is that? The blood test is simple, but it's only good for detecting lesions that are slightly advanced. It doesn't detect early lesions. So we're not recommending that to be used universally yet. So the second one we think about is stool examinations, okay? And there's something that will be mailed to you at home with the instructions and you drop it back. It depends on which company makes it. There are different ones that you do. If you belong to a high risk, meaning that you've had a colonoscopy, there are things that were removed for you, family members with cancer, you shouldn't be doing a stool exam. If you are average risk, you have the option of choosing a stool exam or colonoscopy. So for the individual who was asking, if you are average risk, and to get a schedule to get to colonoscopy is going to be 6 months, 9 months, or whatever it is. If you are worried, it is entirely reasonable to do a stool exam. The key thing, though, is that when you get the result, please act on it. If it's normal, depending on which one you did, you may have to do it again in 1 year or 3 years. Either way, you need to follow up. If it's abnormal, you need a colonoscopy, and you will be fast-tracked to get a colonoscopy. So again, It sounds almost unreal that a gastroenterologist is telling you that not everybody needs a colonoscopy, but for screening, that's the reality. I'll end by saying that, yes, we are not proud of the fact that when you call my office or anywhere looking for colonoscopy, it will be months before you get in there. Here's the reason. When the new guidelines were made, 18 million more Americans will need additional screening. We don't have the capacity in the country for us to do that for everybody. So if all of us are waiting for that when we don't need it, we're not helping each other. Last thing, please speak to your primary care provider or any healthcare provider you see and discuss it, because the conversation starts with discussing it and then they decide what to do about that. Thank you.
I was told that the Cologuard test was actually less reliable for African Americans. Is there any truth to that?
No, there's no truth. And so what we're hearing here is that one of the brands of the stool test is less reliable for African Americans. There are no good studies there telling us that that is actually a fact. Again, some test is better than no test, okay? So if you are in doubt, you don't want to drink the lovely stuff we send you, and I call it lovely because I get abused like every gastroenterologist for the bowel preparation, even though it has nothing to do with us. So some test is better than no test. Don't let anyone say that they stick their finger down the backside and smear on the card. Those tests in today's world as a gastroenterologist is useless.
Again, these are some wonderful questions and wonderful discussion. And as I told you all when we started this conversation that this was interactive. So I have a quick question to ask. Poll, how many people in here have a primary care physician? Wonderful. Okay. How many people in here see their primary care physician once a year? Okay. How many people in here are current with their preventative screening? Wonderful. If you weren't able to put your hand up, I would encourage you to make sure that when you leave here, that on Monday that you do that, because obviously, you know, prevention is very important. Misinformation is very vast. And if you are not staying current and you don't have a good relationship with your primary care physician and with physicians that you trust, you know, you're going to get sick and so forth like that. But if we can prevent those things, that's really important. I have another question, and this one's for Dr. Williams. It says, does Hamilton Health specifically have a treatment, or are they aware of the drug problem called space? It's a huge problem in Harrisburg.
So there are several new designer drugs coming out. That's one of them. Again, for those people, there really have been studies done on how to treat that drug the best. So what we highly recommend is people getting into inpatient therapy. We actually can start with outpatient, but the bottom, you know, again, there are a lot of new drugs coming to Harrisburg. I mean, the worst is the fentanyl. I think in this, I really cannot leave without saying this. The fentanyl, which is what's killing people, well, everybody should have a Narcan in their car, in their purse, because if you see somebody passed out, put that in their nose and you can save a life. Fentanyl now is a clear drug that's actually 10 times worse than heroin, and so people overdose quicker, and they're now mixing it with everything, from the cocaine, the heroin, the weed, the marijuana. So some of the stuff that our kids are getting off the street is now laced with fentanyl, and we're having people die, young people die at young age just from smoking some weed. It's being mixed with everything because it gives a person a better high. It's clear. It doesn't have a smell to it. It's horrifying. And so they're mixing it with the crack. I had one patient, she and her husband went to, they smoked crack together. Her husband fell right over and died. And luckily she hadn't done her bag. And when they took the bag, they found out it was laced with fentanyl. So all the drugs right now are being laced with fentanyl, including the pills. They're making the fake Percocet pills that they're selling on the street that a lot of people are taking. And basically, even those have fentanyl in them. So you've seen people that are just going to just get high for the day, and they drop dead. And it's our youth. It's people of all ages. And I recommend everyone get a Narcan. They're free. Actually, you can go to any Rite Aid or any pharmacy, and they'll give you them free. And it's something we use as a community to protect each other and that if you see somebody out on the ground, don't walk past them. It's a very simple thing. You just push it and it goes up their nose, and you can save a life. But as for the question of that drug, it's many different drugs coming out right now. And again, we recommend them first getting into see us so we can do an evaluation on them. Because oftentimes you see people that are taking that particular drug, they're taking something else that we can actually help them with. Or try and definitely get them into some type of rehab, whether it be inpatient or outpatient.
I see that one of our exhibitors is the Dauphin County Department of Drug and Alcohol Services. I know a couple years ago when they were here, they were giving out free Narcan, and I will tell you, I took a bunch of those home with me at the end of the day. I keep one in my car because I had a friend actually tell me that they were driving on the turnpike and her son went into the bathroom and somebody was overdosing in the bathroom on the turnpike. I have one for I gave one to my daughter and her friends, and I was just like, because, yeah, of course, I would encourage them not to do drugs or whatever, but, you know, when teenagers, you know, people, they don't know what they're taking or whatever like that.
Exactly.
So, and if it can save and prevent a life, you know, one, we encourage you not to take drugs, but, you know, but I'm going to check to see if they actually have some free Narcan or whatever like that. Okay, this is another question for you because I can't answer myself. But Narcan administrating, do you have to be careful when using Narcan when touching someone who is snorting cocaine?
The way that you really shouldn't have to touch up in their nose. It goes into the nose. You just push it. So you really shouldn't have a problem with that.
I'm going to pivot real quickly to ask Dr. Stacy specifically, if we're talking about drugs and drug use, okay, mental health and drug use, not only just on the patient, but maybe their family, their friends.
You finished? Okay. So when somebody is abusing, using, and then addicted to a substance, what you find is it not only impacts them, but it impacts the entire system around them. And it's complicated because there's a tendency for us to do things to take care of them because we love them in the middle of their addiction, but oftentimes we can be doing things that are enabling them to continue in that addiction. A good example is that you're calling people at their job the next day to let them know that they won't be there, or you're giving them money for rent because they're spending their rent money on their habit or addiction. Another way that might be happening is, in fact, that somehow you're making the addiction happen, or helping them buy or purchase it because they say that they need it. But families are very, very, very impacted, and it can be completely disruptive. The word disruptive doesn't feel strong enough. Destroying of a family system, if you will. So there are resources for people who are living with people who are drug addicted. Al-Anon is a really great one. My guess is that Hamilton Health has some kinds of survivors or family group as well to help you to navigate it. But it's devastating when this happens to a family. I can remember in the crack era, people, addicts stealing TVs and stealing money from their family and doing things that were completely terrible. I also think that you have to take care of your own mental health in that process, and so it may be a good time for you to seek out some additional support for yourself, and that could or could not be in the form of therapy, the Al-Anon or other support groups. I also think that it can be stressful and a little crazy making that this is happening, and why my person. You hear people talk about tough love all the time, and I think that that is a real thing. and can be helpful in the addiction in the sense of helpful to cut it off. And so you may have to put somebody out of your house or not give them money when they say they need money for rent, or just to make really difficult decisions in the short term so that it can help particularly disrupt the addiction cycle in the long run. You have something to say about the support at Hamilton around that too?
Two things. So both our STD program, both our HIV program, as well as an MAT program, part of what we do is one of the things I added is we sure everyone's screened for depression, and basically we refer them to our behavioral health center that we have at Hamilton. So both our HIV program and our MAT program has linked with it behavioral health. That's a major part. And one of the things I did want to briefly touch on that you said, she said they sell TVs. What a lot of people do is basically it's sex for drugs, which then puts them at risk for HIV and STDs and everything. So we have a lot of people, when people run out of money, they're having sex. And again, another reason to be sure that they're actually, to get the money or to get the drug. And again, people need to be screened for HIV as well and Hep C, and that's also part of our screening with our MAT program because we know people are doing that. And we do that often during the year because we know if people relapse. Our whole issue with our MAT program is meeting people where they are. Our ultimate goal is to get people to stop, but the best thing we do first is get them to decrease it and cut down because that's how it goes. Because we found a lot of times that they're trying to do the, people go into rehab and then we find that's not what happens. And we stay with our patients even after they've become sober to be sure they don't. I unfortunately have to leave, and I just want to thank you all for coming, and I just think you all are amazing to be here, and thank you for having me here.
Thank you, Dr. Williams.
Good to meet you. So I also wanted to add just one thing that people oftentimes, particularly our people, will make an assumption that they can just stop. That Dr. Williams talked about kind of titrating it down, but what I want to say is there is a mental component to addiction, that people are medicating trauma or difficulty or actual mental illness, but there's also the physical part of it, that the body craves it in a way that not in the way that you crave cheeseburgers, but that physically the hormones and the other pieces of your body are craving that particular drug.
We are coming up on our time. I have one more question that was here. And so, but like we said, we're going to stick around to answer questions afterwards because I don't want to run over time because I am not going to get into trouble as the moderator and I want to be invited back. So I'm going to get one last question.
I'm going to direct it to you, Dr. Stacy, because Dr. Williams had to leave. I have a 34-year relationship with a very wonderful friend. Unfortunately, she's an alcoholic now. And it's over heartbreak, marriage. And nothing no one seems to do, helps her because it just aggravates her. I don't know what to do anymore besides pray, which I constantly do for her. But the most alarming...
Which is good.
Absolutely. So the biggest thing that really alarmed me because, I honestly distance myself because I can only take but so much, and my health matters. But we were out to eat, and she was asking for beverages, and I'm looking like we're at Cracker Barrel, And then she asked the lady that
actually Cracker Barrel is serving alcohol right now.
That's what she was getting to, and I was blown. I was just sitting there, and this is a very beautiful person inside and out. And unfortunately, no matter, she's around a lot of people that kind of coddles her. I'm the friend that's going to tell you the truth, but I don't want to hurt you, because I shoot straight from the hip. So I'm just trying to figure my ways of how to deal with her. It's very mind-blowing to see a beautiful spirit 34 years constantly go down the drain.
Sure. Well, I think when you find that somebody is struggling with something, to continue to berate them about it is not necessarily helpful. Something that I was struck by what Siobhan said earlier is that people come to me for care, not judgment. And so that really kind of moving in that way is important. And so you say your piece one time, or maybe you just say it once a year, but that's just for you to continually be confronting somebody about their behavior, because they are grown. And grown people don't oftentimes respond well, particularly when they're caught in an addiction. And so that's my first thing. I mean, even as a therapist, if I'm working with someone who's dealing with substance use or abuse, it's not the topic of conversation every particular session that I'm working with them. And so it's important to remember that. Also, I think you setting boundaries is important, and to know that if alcohol is around, it's likely that she's going to engage because of, one, the mental addiction to it, and also the physical addiction as well. And so I would be conscious of that even where you choose when to socialize. And unfortunately, with substance abuse disorders, we have to remember that in order for you to be responsible for something, you also have to have power to do something about it. And the fact of the matter is, when people are dealing with addiction, we're mostly powerless to make it different and to do something about it. And we don't like to see ourselves that way. No, you're powerless. And so until they are ready to make a choice that is different, your best choice is to love them, to pray for them, to speak your piece, but not often.
I think that's a great way to end the Ask the Doctor panel. I'd like to thank all my colleagues for this morning. I would like to thank you all for coming. I want to make sure that you all remember that it's the save the date for next year, October 10th, which is going to be here again starting at 9 a.m. But I don't want you all to leave, because this conversation with talking to the physicians is going to continue. In about 5 minutes, we're going to start with Dr. Saeed, who's going to talk about understanding your risk factors for cardiovascular kidney metabolic syndrome for you and your loved ones. So again, thank you to the doctors for the panel, and I hope that you all will stay around for Dr. Saeed.